Good afternoon. My name is Mohammed Al-Garhi. I'm a consultant psychiatrist, and I would like to introduce to you the moderator of the first session in track 2, Dr. Arlene Cook. She's a clinical psychologist trained in USA, licensed to practice by Health Authority of Abu Dhabi and in the Republic of Ireland. She earned her PhD in clinical psychology in 1996 from the University of North Carolina at Chapel Hill, and has since accumulated over 20 years of experience working internationally with diverse populations across various mental health sectors in USA, Ireland, and in Abu Dhabi. In addition to running her own private practice for a decade in North Carolina, USA, she has also worked with both outpatient and inpatient acute and residential treatment centers across the lifespan, and as a senior clinical psychologist in a multidisciplinary community mental health services in the Republic of Ireland for 10 years, followed most recently by 2 years with another provider in Abu Dhabi. Dr. Cook specialized in training that includes a level 4 training in dialectical behavioral therapy, cognitive behavioral therapy for eating disorders, and third wave cognitive behavioral therapies such as mindfulness and self-compassion based approaches. So would you please, Dr. Cook, to moderate the session. Thank you very much.
Thank you very much, Dr. Mohammed, for the introduction. I am honored to introduce to you Dr. Nahed Jabir, who will be presenting on the topic of adolescents' online risky behaviors during COVID-19, the impact of digital platforms on adolescents' well-being. Dr. Nahed is a pediatrician and adolescent medicine consultant, head of the unit of adolescent medicine, faculty on the Oman Medical Specialty Board. She is physician lead and has worked on establishing adolescent medicine in Oman as a pioneer service. She graduated from the University of Toronto and the Hospital for Sick Children. A clinical teacher, University of Toronto's Department of Family and Community Medicine. She's recognized by His Excellence, the Minister of Health of Oman, as a winner of one of the best projects of the year, 2017. Establishment of adolescent medicine services, and as the award winner as the best faculty member and trainer for pediatric residency training program of the Oman Medical Specialty Board. She is an advocate of child and adolescent health and serves on numerous committees nationally and internationally. She is a speaker in local, regional, and international conferences like our own. Clinically, she works with teens around issues of eating disorders, coping with chronic illness, adherence and compliance issues, reproductive health, substance use, body image, bullying, and abuse. Her main focus is screening, early intervention, and prevention of health consequences resulting from internet misuse and ensuring adolescents' digital life safety. Please welcome Dr. Nahed.
So we'll be speaking in the coming 30 minutes or so about adolescent online risks during COVID-19. We'll talk about the well-being and the impact of digital platforms during this era of pandemic. So COVID-19 pandemic has led to an enormous rise in screen time, where schools are closed and strict measures are imposed by government across the globe. And this means like more and more families are relying on technology as well on digital solutions to keep their children learning and entertained and connected to the outsider world. But not all children and not all parents that are equipped with the knowledge and skills to search and to navigate the digital platform and to be safe online. That's why the choice of this topic to probably highlight on the health consequences that may relate to the misuse of technology or to the screen time during the pandemic of COVID-19. And we're not here to scare anyone. It's just to highlight on the risks that adolescent mainly, and we will speak about why adolescent mainly in the few minutes. And there are, of course, substantial opportunities to the digital world that may bring lots of knowledge and skills. However, a diverse range of risks may come along. So the highlight of first, I have no conflict of interest to declare, and I assume the responsibility to ensure the scientific validity of the content of this presentation. The outline of my presentation will be focusing on the digital generation, which describe this generation of the digital world. We'll talk a little bit about the neuroscience and brain development and why we focus on adolescent age group in terms of their brain development. And we will talk a little bit about the global demographic, how much do they represent from the entire population across the globe, and what are the health consequences. I'll be focusing mainly on the mental health consequences, and I will skip the physical health consequences of misuse or intense use of technology. What are the preventive measures and whose role and responsibilities at what we can do as responsible or carer for adolescents to prevent those health consequences. So within this presentation, when I say adolescent, the meaning of 10 to 19, the age group of 10 to 19 years as defined by the WHO. So this is the scope of adolescent practice. However, if we speak about young people, it's a more an inclusive for a little bit beyond adolescence year until the age of 24. And now we'll get to understand why 24. So along with the adolescent age group, it comes a stage of life, which is adolescence, that is the most beautiful, lively and exciting and healthiest stage of life. However, along with this adolescence stage comes lots of challenges, psychological, social, and many changes are happening all at once. So it's basically a transition between childhood that requires so much of monitoring and parents hands-on and on board to a phase of life where more autonomy and more independence is required. And the adolescent will be more responsible for their behaviors. However, we said like we all know, all healthcare workers, they know and understand that adolescents are, as a stage of life, and adolescents are the healthiest age group among all the other individuals. Yet, the overall morbidity and mortality increases by 200 to 300 folds during adolescence year. So this is really weird, and we have to understand why. This is in relation to the risk-taking behaviors and control of emotions that shape adolescence year. And we'll get to understand why in a bit. So parents and society put usually very high expectation on adolescents, assuming they have grown enough to take adult responsibilities. Yes, they are in the bodies of adults, but they cannot take the responsibilities of adults. And this may result in lack of understanding, lack of monitoring, because there is a mismatch between the physical maturity and the psychosocial maturity. The physical maturity precedes psychosocial maturity, and this explains why adolescents are impulsive and their actions are impulsive, and they don't appreciate the consequences of their actions. So why is that? Why adolescents think and act differently? In the past, we used to know that, especially in the talking about the neuroscience, there is a kind of revolution in the neuroscience in the last 20 years in regards to the development of the brain, where the initial thought was that the brain will continue its development in childhood. However, the brain normally develops from the back to the front. This means the frontal lobe is the last to develop. And the frontal lobe, as we all know, is responsible for the executive functions, where the planning, the problem solving, the decision making, and control of impulsivity roles. However, since this part of the brain will not be fully developed until mid-20s, then this explains why adolescents are different and why they take risks and why they do really don't appreciate the consequences of their actions, and they are still in need yet for taking some autonomy and responsibility, but yet they have to be monitored until they can fully function into adult world. So basically, we can consider that the brain will be under construction until mid-20s, so somewhere around 24. And that's why I mentioned at the beginning in the first few slides, young people between the age of 10 to 24. So their limited capacity of self-regulation will put them at risk as they navigate life and technology and surfing online. So that's why it's a unique population that needs more attention. And of course, here I'm repeating that we're not here to scare anyone, and we're not here to promote to go back to the pigeon post era, but to highlight on the risks and to promote for preventive measures and positive online experiences for children to ensure their safety as they surf online through their devices. There are many terms to describe the new generation, and they're used interchangeably. And this is not in relation to the COVID-19. Those terms been introduced in the couple of years since the introduction of digital technology. So, and they are used interchangeably to describe this Gen Z, those people between the age of 8 and 23, and then we can go below that. We now see even as young as 1 year, they're holding devices or 2 years or 3 years. So basically those terms, digital generation, digital native, digital youth, and digital citizens are terms interchangeably used to describe this specific generation. Along with those terms, there is a vocab that comes along where, and this explains the huge gap between the parents and their children, how their children are communicating, and the huge knowledge gap between the life of their children, the virtual life of their children, and the actual life. So if I'll give you a chance to just have a look on a few of those codes and try to decode them, apart from this LOL that we all know, like laugh out loud, but there are other terms that you can't even decode. And this is, and if you can search their devices, you can see this type of language used where it's a huge barrier and you don't understand what's going there into their life. So MOS, CD9, P911, PAL, PAU, and so on. So if we'll try to decode, let's have a look on what does those codes means in the teen language. So MOS, mom over shoulder, CD9, parents around, P911, parents alert, parents are listening, PAL, parents are watching, PAW, this is the language, parents in room, parents over shoulder, and another list of. If you can see here on the left side of the screen, mom, parents, 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 and this explains a stage of development during adolescence where they're seeking autonomy and independence, and they don't want their parents to know what they're doing, either in the offline or in the online. And actually, in the practice, when they come to the clinic for any type of assessment, for whatever reason they are referred to the adolescent medicine clinic, you can see the dynamics between the teenagers and their parents, where the parents will be surprised, how I didn't know about that, why he didn't tell me, though we are close to each other, though we have open line of communication, but she or he didn't tell me. The parents, they assume that their children, they will come immediately to tell them if they face any challenges or any problem, but it's the opposite. They are the least that the children will come forward to tell their parents, especially in adolescent age group. Another type of texting is the Arabizi, which is a mixture of Arabic and English among the people who are Arabic speakers. And they have a combination between both languages. And then here it will become even more complicated and more gap in terms of the communication. So having said that, the pandemic means more time on screens, and millions of children are at increased risk of harm as their life have moved to virtual world. So according to a report from the UNICEF, and this is a preliminary report, we don't have yet exact data. However, as of April 2020, which is almost like few months back, the school closure involved 188 countries, impacting more than 90% of the world student. As well, there are more than 1.5 billion children and young people affected by school closure. And the internet usage has gone up, of course, by 50% in some parts of the world. The pandemic has transformed their education and their learning, the way they communicate with the outside world, how they maintain friendship, and how they spend their leisure time and their engagement with the outside of the world during with the virtual platform. Especially, it can leave vulnerable children who are not prepared yet to this virtual world to many of the risk and risky behaviors. Children age 13 and older, we assume that they are familiar with the digital platform. However, the pandemic has introduced younger children who are not prepared with the knowledge and skills to the entire virtual world and put them at even more risks. Physical distancing measures are likely to increase. Why we speak about that? Because it will increase their exposure to new contacts, especially we have said about the communication gap and the knowledge gap and the skills gap between children and their parents in terms of technology. And it will expose children to predators who groom them for sexual exploitation. This, before the pandemic, was really a public health concern, and we expect with the pandemic to be even worse. Let's have a look on how much adolescent they represent from the global population. There is 1.2 billion adolescents. So basically, and roughly, we can say they represent 20% of any country population. So it's kind of significant. Looking at our region in the Middle East and North Africa, as we can see here in this table, we are considered really young. Our region has very young people, where, for example, in Oman, 50% of the population are less than 25 years of age. If we look at Saudi Arabia, 46%, in Lebanon, 40.5% and 40%. So pretty much we're considered young population. As many children, learning experience are being reshaped by the sudden introduction of remote learning, including technology and virtual platform, as a substitute of the actual classroom and the physical attendance to school and schoolyard. And it is the right for every child to access health, education, and to be protected from any harm. Any act, either intentional or non-intentional, offline or online, that may cause harm to any child is considered an act of child maltreatment. So during the pandemic, a huge transformation, as we have said, in the lifestyle in terms of the connectedness to the outer world, with more time online. So what happens if this developing brain that we have talked about, that's still under the process, is still under construction, is really overstimulated by so much of technology? Looking at the internet penetration in the Middle East, and this is the report from April 30, 2019, as we can see here, the world average internet use is 56.8%. We are at 67.2 in the Middle East, while the rest of the world is at 56. So pretty much we're great consumers, and we're consuming more, and our children are really more exposed to the risks that comes along with those digital platforms. This slide is pretty much as the previous one, but this is a comparison between the internet penetration from 2009 until 2019. As you can see here, the gray line is representing the global average, and underneath just this tiny black is the rest of the world, while the blue one is the Middle East. As you can see, our curve from 2009 to 2019, we have more than 60% internet penetration as compared to the around 55% for the rest, 55, 56 for the rest of the world or the global average. So again, this is a most recent one as of August 26, 2020. Having a lot of research has been done to assess the teenager and their use of technology, even before the pandemic, definitely. And there are lots of studies ongoing during the pandemic that will reflect even more numbers. So if we look at this study done in 2016 in the United States, and it shows like more like 78% of adolescents, they have smartphones. Like we can pretty much say, even if we define adolescent age group between the age of 10 to 19, we can see even in childhood, less than 10 years of age before hitting adolescence, they own smartphones as well. So we can expect this number to be definitely higher. 95% of teens go online either through a laptop or a tab or a smartphone or any access at school. 80% of teens use some kind of social media, and 50% report feeling addicted, and this is really concerning. And here we're talking about 2016. 1 in 5 teens have been cyberbullied, and we'll be talking about cyberbullying as a major consequence of online exposure. And teens who have been cyberbullied are at a higher risk of attempting or committing suicide. And we can't skip a month or 2 or 3 in the West without having a teenager who committed suicide or attempted suicide because he's been cyberbullied. So it's a kind of a public health concern, and we call it the pandemic of our era. The time spent with media, and this is again in the same study, more than 7 hours. And here we're talking about the entertainment. This is before COVID. So how about now they have their education online and they have their entertainment online. So I expect this number to be, of course, higher than 7 hours, definitely. And 4 in 5 adolescents report sleeping with their phones. We all know, and we all see, like if you have a teenager at home, or a cousin, or a relative, or a sibling, or a friend who has a teenager, we do have our phones in our goes with us into our bedrooms, and this is for the fear of missing out. There is a phenomenon called the FOMO recently, because they want to be on top of everything and they want to catch up with every single notification. Especially talking about adolescents, they want to fit in within their age groups. So they want to be always connected, and they don't want to be missing out on any communication or any notification happening on the social media platforms, and they're not updated with that. 1 in 3, and this is according to the UNICEF for every child, and this is in 2017, in one of the studies, they have found that the most connected age group worldwide are adolescents, where 1 in 3 users is younger than 18. And here we're talking about children, anyone who is below the age of 18. 71% of them are between the age of 15 to 24. So again, middle adolescence is really a very tricky stage. Here in our region, I will share with you a study that was done in Oman, and this is definitely before the pandemic, to reflect on how the perception of adolescents about technology and how it may impact their life. 85% they experience illegal downloading, and then like those pop-ups that they come either intentional or non-intentional about inappropriate contents that might be sharing adult content in 55%, and 82.5% searching for inappropriate content intentionally, and 25% they are harassed online. So those numbers are really significant and are scary. And we expect, we assume that with the pandemic, those numbers will be definitely higher. So with this intensity of digital revolution, I will give you a few seconds to think. If you have any guessing, how many apps are out there in the world? Just between yourself, just try to put a number, and then I'll give you just a few seconds. Okay, are you any close to that? So basically Google Play just alone, 2.2 million, Apple Store, 2 million, and there are of course the rest. And the scary thing or the alarming sign is that more than 73% of those apps are free to download. And you can fake the age, and those apps, they're not usually approved by educators, because if we look at how many apps per month the developers, only in Apple Store, there is around 1,500 apps a month to be released, and it goes by the developers without going through the proper channel in terms of assessing the contents, if it is relevant to the age group. So even the educators, they don't have enough time to catch up with this rapid speed of app development. Definitely, there are positive aspects, as we have mentioned earlier, in terms of enhancing communication, new knowledge, in health also, probably joining a support group, getting more educated about a specific disease, especially if we're talking about adolescents with chronic condition. It opens other opportunities to connect with friends and reinforce offline relationships. But again, there are the negative side of two sides of the coin. The impact on health. So here, they're divided between mental health and physical health, and I will be focusing only on the mental health consequences. Internet addiction disorder, I will be speaking a few words about that. Depression and cyberbullying, which is a global pandemic, and lack of sleep, poor concentration and memory dysfunction, and they are all studied by evidence-based medicine. Poor academic achievement, impaired social skills, and social isolation. Eating disorder that falls in between physical and mental health, both. Obesity, it falls between physical and mental health as well. Distorted body image, it falls between physical and mental health, it's overlapping. Again, migraines, risk sexual behaviors, sexual abuse, and so for the risky sexual behavior and sexual abuse, I just can share with you, just during this pandemic, I had to deal with 3 adolescents with the illegal teenager pregnancy, because they were blackmailed and they were threatened online after sharing some of their pictures, and they had to meet their predators, and they got pregnant. So again, it's really concerning. I'll speak a little bit about the internet addiction disorder, which is the silent addiction. It is a common compulsive, impulsive disorder as classified by the DSM-5. It is compulsive behavior online related that causes functional impairment, and it is unlikely to be detected unless we screen for. In the practice, very rarely that you can see adolescents who will come forward voluntarily to speak about any type of addiction. Either we are talking about substance, or we are talking about their misuse of the screen time or of the internet. So the hardship during COVID-19 pandemic, the social isolation, lack of activities, they're not going out to do any of the activities, sedentary lifestyle, restriction to take healthy risks. We know adolescents, they want to experiment, and there are healthy risks where they're gonna try on, and they're gonna be exposed to the entire world outside within the healthy risk, not the unhealthy risk behavior. So an increased substance use as a mean of coping, because they are so distressed, and there are online shopping of illicit drugs that really were tracked by the Statistic Center in the United States, where it's more active during the pandemic of COVID-19. And the evidence behind the changes that may happen because of the internet, the MRI shows signs of atrophy of white matter in the brains of heavy internet users, quite similar to the finding with the functional MRI with the actual substance users. So there is the evidence behind it, and this could affect their concentration, their memory, and it will affect their decision-making, their academic achievement, their academic performance, and it may cause a cascade of consequences. Cyberbullying, this is a major concern, and we do see it in the practice. I can barely, I can assure you that most of the teenagers I screen in my clinic for cyberbullying, they screen positive for a certain level of cyberbullying, either kind of communicating hard word, commenting negatively on their personality, on their appearance. And so the cyberbullying is the online form of the traditional bullying that happens at the schoolyard. It's an aggressive, intentional act where sending offensive and messages that is rude and that causes emotional distress, criticizing that person or threatening that person. The bad thing about cyberbullying that chases the victim 24/24, like in the traditional bullying that we see it in the backyard. So they get a little bit of relief when they get home from the school, while the online or the cyberbullying or the online bullying, it chases them 24/24 hours, because they will come home and they are home and they are connected to their devices. It is strongly related to depression and suicidal ideation. That's why it's a major concern for us as healthcare providers working with adolescents. Another consequence is the online child abuse, which is a unique form of child abuse, cyber molestation. And it doesn't happen face-to-face. It doesn't require physical contact. They just share images, and they ask children to perform on some acts in front of the screen, and they are victims of harassment and sometimes rape when they ask them to meet physically. So the sexual exploitation in COVID-19 pandemic, because children and adults are spending more time online, so the predators are connected to their screens, and the children and adolescents are connected to their screens. So sexual extortion, sharing personal photo, access to pornography, grooming, and sexting. And in regards to access to pornography, I have a couple of teenagers who are really searching for such type of contents, and they're kind of addicted to pornography. Another form or another risk is the domestic child abuse, where the lockdown, the loss of income, the isolation, and the high level of stress and anxiety, while with parents working from home, will increase the likelihood of domestic abuse. Unfortunately, and definitely, we don't have the exact numbers and figures. This will be only known after lifting up the pandemic restriction. Especially, it is difficult for children to report about their predators when they are with their parents at home. Inappropriate contents that may really expose adolescents to really sexually aggressive behavior, and it causes distortion of the ideas about healthy and sexual behavior, and may lead to unhealthy relationship in the future. There are 70% of adolescents aged 15 to 17 are exposed to accidental viewing of pornography, and some of them, they are intentionally looking for such contents. Another form of abuse is the online recruitment of adolescents to engage them in violence and political conflicts, and we have seen it in the political conflicts happening in the Middle East, where those adolescents were recruited by terrorists. Poor sleep hygiene is a major concern in most adolescents as a direct impact of screen time. They spend hours surfing the net, and this results in poor concentration, poor academic achievement, and as a result, it may impact their mental health in terms of depression and anxiety. Obesity, because of the sedentary lifestyle, they are always sitting on their couches, on their chairs, either for the educational purposes or for the entertainment purposes, PlayStations or the consoles, video games, that has put up the obesity on the rise. And of course, there is a link between obesity and social isolation and depression. So it affects directly their mental health. Distorted body image. There are lots of evidence for a relationship between internet use and body image, especially for young female adolescent, and the stereotypical image of the female in the media, where everybody has to be thin, like the culture of thinness and shape and size focused, especially through those following those celebrities and promoting for being slim and engagement in unhealthy food behaviors. So adolescents are exposed to many risks in terms of developing eating disorder, especially anorexia nervosa. The Snapchat dysmorphia, which is a term to describe the idea of changing your face to look like a filter, and we do see it. No one now has any photo on the social media without using any type of filters. And those filters can lead to body dysmorphic disorder, which is a mental health where the person will be preoccupied by an imagined physical effect that's not real, it's not the reality, where they perceive themselves as ugly and they avoid the social exposure, and they turn so much into plastic surgery to improve their appearance. The impact on personal identity, where every post is there online. It's a kind of a future public record. So whatever is posted, even if we deleted it, it will remain out there and it will affect their future career planning. So now, having talked about the consequences, how we can help the young generation. Actually, it's a multi-sectoral involvement, either for us as healthcare provider, no matter what is our discipline, either we are pediatrician, we are subspecialty, we are psychiatrists, we are psychologists, social worker, anyone who works in the health care should be more oriented about how to address those issues and how to screen a little bit whatever allowed in his discipline. So us as healthcare providers, schools, legislative authorities, and the companies, the technology companies. Speaking about the healthcare provider, to become educated about the public health risk of media and encourage healthy use of media and urge parents to monitor for potential problems. So a recommendation for healthcare provider, just at least to ask one or two related questions related to the media, like how much time do you spend on the screen, and what is your favorite topic? What is your favorite game? What is your favorite social media platform? Your favorite app? How much time do you spend? Is there any contract? Is there any routine at home? Do your parents monitor? So just any type of question, one or two will be enough to figure the dynamics between the teenager and their parents, and if there are red flags to be identified. In addition to, to let the teen know that keeping an open line of communication with well-established routine, kind of contract, as I have mentioned, and the right, tell them about the right to check their devices. And it's not like you're being a police chasing their activities online. It's just because you are their parents and you care about them and you trust them. Make sure that you tell them that you trust them, but you don't trust the world out there. And that you should know their passwords so they are really protected. And this is variant between the age group. Of course, you cannot tell your 16-year-old that you want to know her password, but of course you can tell a younger child. In addition to promoting for a culture of a digital citizenship where they have the awareness about the digital etiquette and what they can do and what they cannot do online. Here I will share with you the screen time recommendation as per the American Academy of Pediatrics. Anyone who is below the age of 18, they should avoid any media use. Between the age of 18 to 24, high quality, very limited, and co-view with them. Just a little bit of a short cartoon or a little bit of a clip of an animation. 2 to 5, limited to 1 hour, and co-view. You cannot leave your 2 to 5-year-old watching freely. 6 years and old, definitely you maintain this type of conversation about being responsible online, appropriate behavior online, digital citizenship, reviewing their contents, educate them about their privacy setting, and of course, monitoring. Promote for a culture of edutainment, which is the combination of using the online platform for education and for entertainment in a balanced way. And of course, maintain some areas in the house where all the devices can be in the mostly highly trafficked area in the house, like the family room, and avoid TVs and consoles in the bedroom. And dinner and family time, no TV, no devices. Entertainment media for 1 to 2 hours per day with high quality content, and co-view with them and approve what they're watching, and avoid any type of screen for less than 2 years old. For schools, definitely embed the citizenship, digital citizenship within their curriculum, and promote for healthy online behaviors. Legislation and legislative authorities to have kind of laws in place to regulate the safe use. And here I will share with you one of the Google and YouTube where they were punished kind of really the most large, a huge fine of 170 million, and this was just recently because of illegally monitoring and tracking and served targeted ads to young children for the purpose to gain money out of that. Here in Oman, we have many articles in the Omani law to show the consequences and to prohibit any kind of cyber of blackmailing. And it is reflected in many of the articles, penalty with imprisonment or fine to pay. Here, I will share just the last few words about the red flags and signs requiring your close attention, either as a healthcare provider or as a parent. Increase anger when internet connection is lost, even for a short time. This is what the parents will report to you in a clinical setting, or spending so much time online and turning the monitor away when they see you coming into the room, or starting to receive strange phone calls at a strange time. Usually they come from strangers. Foreseeing the future, definitely technology will never go away. We are more transforming into virtual, especially now with the pandemic that has taught us a lot. So we expect smart clothing by 2025, where people will start wearing clothes connected to the internet. And I think it's really time to prevent those risks. So it's the kind of throwing your child at the deep end of the swimming pool, or just introduce swimming with the proper equipment at the shallow end before throwing them into the deep end of the pool. And here I will end my presentation. And thank you so much for your attendance and interest in listening to me for the last 40 minutes, actually. Thank you.
Thank you so much, Dr. Jaber, for a very, very informative presentation. Our next speakers, Dr. Dennis Ugren will be joined by Mr. Ben Hao Ching to present on the topic of self-harm in young people and COVID-19. Dr. Dennis Ugren graduated from medical school in Ukraine in 1998 and came to England to undertake his postgraduate training. He completed his higher training in child and adolescent psychiatry at Guy's and the Maudsley, and is currently a consultant in child and adolescent psychiatry, leading the supported discharge service at South London and Maudsley NHS Foundation Trust. Dr. Ugren is also a lecturer at the Institute of Psychiatry. Dr. Ogrin leads a program of information exchange between the UK and Ukraine and organizes annual conferences on psychiatric service development in Ukraine. His main professional interests include prevention of borderline personality disorder and effective interventions for self-harm. Dr. Ogrin is the author of Therapeutic Assessment, a novel mode of assessment for young people presenting with self-harm in emergency. He is the chief investigator of a randomized control trial of supported discharge service versus treatment as usual in adolescents admitted for inpatient care. Dr. Ogrin is also undertaking an academic director role at Maudsley Health at the Al Amal Psychiatric Hospital in Dubai and leading the research, education, and training portfolio. Mr. Ben Ho Ching is a recent MSc graduate in child and adolescent mental health at the Institute of Psychiatry, Psychology, and Neuroscience. He has a strong research interest in emergency presentations and community treatment alternatives for children and young people who self-harm. Welcome, Dr. Ogrin and Mr. Ho Ching.
The young people with self-harm. Now, when you look at suicide around the world, you will see that there are different trends. This is obviously pre-COVID in different countries. So the countries that look yellow, brown to sort of deep brown, they experienced an increase in suicide rate, whereas the countries with sort of green, blue to dark green colors are the countries that reported fewer suicides, so the trend towards reduction of suicides. You will see that pre-COVID, the UAE was one of the countries with relatively low suicide rate, but actually reporting an increase in the prevalence. Now, when you look at different age groups in relation to suicide around the world, then you will see that in the vast majority of countries and regions, you would expect an increase in suicide over time. And so the oldest people in each population would be at the greatest risk of suicide. With one notable exception of Southeast Asian women, where we have an unusual bimodal distribution of suicide prevalence, with very young women and very old women being at equally great risk of suicide. When you look at European prevalence of suicide, then it is clear that it's mainly the Baltic, East European, and Northern countries that experience significantly more suicides in young people than Mediterranean and Southern countries. It is probably not fully explained by biased reporting and almost certainly reflects some underlying differences in suicide rates. In the UK, we have seen a gradual decrease in suicide rates in both males and females. You will know, most of you will know that male to female suicide rate is something like 3 or 4 to 1 in most Western countries. But you can see that both the male, which is the green line, and the female, which is the dark blue line, suicide rates have been gradually reducing over many years in the UK. When they hit a plateau around 2011, 2010, then there was a plateau with some increases, but then in the last 2 years before COVID, so the last data available is 2019, we have seen a fairly sharp increase in suicide, especially in males, but overall as well. When we look at the method of suicide, then the key method of suicide in the UK in all age groups is hanging. Now, you can see on the left that hanging is by far the most common method of suicide in males. In females, something very interesting happened where as recently as early 2000s, self-poisoning was the key method of suicide in females. Then around 2009, 2011, there was parity. So females were killing themselves by self-poisoning or by self-hanging equally. And then since about 2013, there was a definitive increase in the suicides by hanging in females. And that gap keeps growing. When we now look at youngest boys and young men, then when I trained, we were told that we are really experiencing the peak of that, and it is true. If you look at young suicides, then sort of late 80s to late 90s was the time with the greatest prevalence of suicide in young males, which was then reducing very dramatically for many years, except as I said in the last 2 years when there was an increase in young male suicide, with a plateau last year. In females, in young females, it's even more dramatic, even though, of course, the absolute numbers of suicides are significantly lower in females. Then in young females, we have seen the highest prevalence of suicide last year of any year since the records began. So there's something very worrying happening to young women and girls in the UK, and that is replicated in many other countries too. Now, the reason why we talk about self-harm in conjunction with suicide is because, as far as we know, self-harm is the strongest known predictor of suicide. For the purposes of this lecture, self-harm will be defined as either non-suicidal self-injury or suicide attempts. So using the UK definition, we think about self-harm as any kind of self-poisoning or self-injury, irrespective of the intent. It's a long debate that has been going on in academia for many years, but that's the way most researchers in the UK think about self-harm. So any self-injury or self-poisoning, irrespective of the suicidal intent. So if we define self-harm that way, then we will see in primary care that the prevalence of self-harm in girls and women is significantly higher than in males and boys. So the reverse is true in terms of the male to female prevalence in primary care to suicide. When we saw 3 to 4 suicides in males to 1 female suicide, the reverse is true about self-harm, about 3 or 4 times more common in girls than boys, and increasing as well. When we look at self-harm as a cause of death, i.e. attempted suicide, globally, then in most Western countries, self-harm is the second leading cause of death after accidents. Except in some years in America, one could see homicides, i.e. being murdered, as the second leading cause of death and suicide third. But if we look globally, then in females, it's actually maternal conditions that are the key killer of young females, teenagers, 15 to 19-year-olds. Whereas in boys who are 15 to 19, then traffic accidents is essentially the main mode of death, followed by violence, by homicides, and then followed by suicides. So that's globally. In the Western world, we clearly see that suicide is the second leading cause of death in young people, behind accidents. Now, is there anything we could do about self-harm? Up until about 2015, my answer to that would have been no. There was no evidence that any psychological therapies made any difference to self-harm at all. In 2015, we published the first meta-analysis, which has shown that we are not quite wasting our time with self-harm. Now, for those who may need a refresher on what meta-analyses are, in here we've got all of the studies that compared psychological therapies with controls, with some sort of a control waiting list or non-specific intervention. So all of the studies are listed here on the left. In here, in the middle, we've got the effect of these studies. So how much did self-harm reduce in a psychological therapy when compared to doing nothing or some sort of non-specific intervention. And the more to the left the overall effect size is, the more the greatest reduction in self-harm was actually seen. So at that point, the studies, the single study with the greatest effect on self-harm seemed to have been the type of psychological therapy which is called DBT, which stands for dialectical behavior therapy. Other studies with promising outcomes were CBT, cognitive behavior therapy, which is the Esposito-Smithers, and then MBT, which is mentalization-based therapy, which is by Russo and Fonagy. So that's 5 years ago. Now, this year, we published another meta-analysis with my colleagues in Vienna, which then looked at some of the updated studies. And interestingly, the effect size for CBT has reduced. So there was a large negative study of CBT by Michael Kaz in Switzerland that showed essentially no difference on self-harm in the follow-up period, except one has to say that the reduction, so everybody, both CBT and control groups reduced their self-harm, but in the CBT arm, self-harm reduction occurred faster. But when we looked at the actual endpoint, there was no difference. What happened in the DBT world, in the dialectical behavior therapy world, was actually the second study published, which was independent and done totally separately from the original paper. And they have shown that it was effective. So in fact, DBT at the moment is the only therapy in child mental health where we have 2 independently replicated studies, which both show the same thing, that DBT is effective in reducing self-harm. Now, at the point of the publication of this meta-analysis, the second MBT paper was not yet available. It is now available. And in fact, the effect on self-harm was significantly smaller than in the original Russo and Fonagy paper in 2012. So when we meta-analyze these 2 studies, it may well be the case that MBT will no longer be significantly different from controls in reducing self-harm. But that's something that my research group is working on now. Now, apart from self-harm, of course, there are other possible targets for interventions. One of them is, of course, thinking about suicide. And for that, again, 2 psychological therapies stand out. One is DBT, as I mentioned before. So it seems to be reducing both self-harm and thinking about suicide. But here also, family therapy stands out. So all of these different family therapies with different effect sizes, you can see, but overall the effect size seems to be in favor of family therapy when it comes to reducing self-harm, thinking about self-harm and suicide. Now, I will take you through very quickly through risk factors for self-harm. You will be familiar with most of them. I might just draw your attention to a couple of recent risk factors that have emerged in the last few years. So one of them is really thinking about young people's sexuality. So worries about sexuality is something that we never particularly used to ask about. But now it is clear that being worried about your sexuality is something that is a very clear risk factor for self-harm. The other thing which is relatively new, and certainly what is new is how potent that is the family history of self-harm. Something that we rarely used to ask years ago, but it appears that if somebody in the family or a close friend self-harms, that's a very potent risk factor for the child starting self-harming. So what predicts thinking about suicide to moving to actually attempting suicide? Again, you will be familiar with most of these risk factors. what I wanted just to draw your attention to is a couple of new ones which emerged in the few years. One of them is body dissatisfaction. I can see that Bruce Clark is listed on the program. I'm sure he must have spoken about body dysmorphic disorder. Now that is something that appears to be a very strong risk factor for moving the child from thinking about suicide to actually attempting suicide. The other interesting thing, which I really wanted to draw your attention to, is smoking. Now, I know that in the UAE, very few, or significantly fewer people take hard drugs or drink alcohol than in Europe. But smoking is a very common behavior, I think, in people, especially in males. And so I just wanted to draw attention that in study after study, smoking seems to be a strong predictor of that moves the young person from thinking to attempting suicide. We don't quite fully understand why this is. It would be an interesting subject for somebody's PhD, I think. But I just wanted to say that it's a known and replicated risk factor. And then finally, looking at risk factors for completed suicide. Again, most of you will be familiar with this list of risk factors. Perhaps one thing that I wanted to draw attention to is the adverse childhood experiences. Now, the literature on that really has exploded in the last few years. So we know now that young people who are looked after, i.e. removed from their biological families into some sort of foster care or state orphanages, then represent a super high risk group for suicide. In the UK, we really underestimated the importance of that group. And I'm doing really several studies, but one of them in particular looking at preventing self-harm and suicide in very young looked after children, so 0 to 5-year-olds who are removed from biological families for reasons of severe neglect or abuse. Now, when the young person comes to A&E, how likely are they to come back? Again, years ago, the risk was estimated at about 10%. Later studies show that the risk is significantly higher. In the last few years, last 10 years, I think, the risk has moved to about nearly a third, nearly 30%. Again, people will come back if you follow them for a long time. And in A&E, of the people who come, about 1% will die in 10 years, and half of them will die of suicide. So not half of the ones who present, but half of the 1%, so 0.5%. The A&E research is interesting in the sense that it highlights the fact that violent self-harm, such as attempted hanging or drowning or jumping from heights, is really a very serious risk factor for completed suicide. And so in comparison to low lethality methods of self-harm, such as cutting or taking overdoses, then violent methods increase your risk of dying by about a factor of about 8. Last year, we had an interesting special issue in a journal called JCPP, which I helped to put together. And of all of the studies we had really interesting studies in that issue. I was very struck by this one, which I wanted to show you, which really looked at an interesting risk factor for suicidality in young people. And they looked at both ideas, so thinking about suicide, and attempting suicide. And what you can see on the right here is a map of relationships of young people within schools. So you can see that, and children with who are thinking about suicide or attempting suicide are in small red dots. So you can see the interesting thing here, really interesting thing here, is that young people who have suicidality tend to keep away from the majority of the children in school, but co-segregate with each other. So they have a little cluster there of red dots, which is something that we really have never seen in this striking, dramatic picture, but it's something that really has to alert us to the risk of a certain group of young people who are at grave risk of dying. So moving on to the current pandemic and COVID, when you think back to the risk factors of the onset of self-harm, repetition of self-harm, or suicide, you will see that a lot of the risk factors that I have mentioned to you about have been very prominent in the last few months during the pandemic. Essentially, we've got isolation. A lot more young people are isolated and lonely. We've got a lot more anxiety. Survey after survey shows that especially emotional disorders are particularly increasing in the population during COVID. We've got an increased risk of domestic violence, alcohol consumption, especially in adults who live with children, and increased exposure to social media. You've heard from the previous talk about the link between social media and suicide and self-harm. And there is no doubt that kids use a lot more social media now than pre-pandemic. So we were really interested to see what was the impact of COVID-19 on A&E presentations. We've looked at probably the largest study of its kind. We looked at over 2,000 presentations to A&E with self-harm, and we compared two time periods. So one was the March to April this year, during the peak of the first wave, with March and April last year, 2019, when there was no, obviously, a pandemic or COVID. We looked at under 18-year-olds, and we looked at all psychiatric emergency presentations, not just with self-harm. We managed to get together 10 different countries, including, I'm very glad to say, the UAE. And the population covered in our study was huge, was over 6 million young people. And we included 23 hospital A&E departments. So what we have found? We have found that the number of emergency psychiatric presentations, for any reason, has decreased significantly. So there was a substantial decrease in the number of kids coming to A&E for whatever reason. In 2019, there was 1,200. In 2020, we only found 800. And the proportion of self-harm presentations has increased. So if you look at all of these presentations to A&E, and then you look at the proportion which was for self-harm, then that proportion has increased substantially. You can see here that in this chart that even though the absolute numbers of presentations has slightly dropped, the relative, the proportion of these presentations actually increased very substantially. So here is, you can see that in most countries it was the case. There was an exception in Turin, in the northern Italy, where they had a slight increase actually in the presentations, and a tiny increase in Livingston in southern Scotland. But otherwise, it was a very consistent picture across the globe. What we have also found that the proportion of the young people who already had a history of coming to the hospital before with self-harm has actually increased. So the interpretation of this is that it's the young people who have never been to A&E that seemed, for whatever reason, to have been very reluctant to come. The ones who had experience of coming to A&E, who knew a little bit about the setup, seemed to be a little less frightened to come. And then we looked at the proportions of young people who had previous self-harm in the community, and we have found no difference in these presentations in 2020. Now, we really were wondering, and our hypothesis was that even though the overall number of self-harm presentations may have decreased, then the severe self-harm presentations, we would see more of that. Now, that was true in some A&Es. So we have found this, for example, in Edinburgh. But in most other A&Es, that was not the case. And so we concluded that overall around the world, there was no increase in the proportion of young people with severe self-harm during the pandemic. The other interesting thing was that we looked at different diagnoses in these young people. And one thing that stood out was that the proportion of kids with emotional disorders, i.e. anxiety and depression, has actually increased in 2020 in relation to last year. Now, we don't know whether that represents the overall increase in the emotional disorders in the population, or that young people with emotional disorders were more likely to come to A&E. But the fact is that during the second wave, one should really expect more emotional disorders in A&E than pre-pandemic. And then the final sort of important finding, I think, was that we have found that young people were significantly less likely to be admitted to an overnight observation ward in most countries. So in some countries, it's a mandatory requirement that anybody who comes with self-harm under the age of 16 has to be admitted overnight to be assessed the following day. That's a NICE guidelines requirement in the UK, for example. We have found that during the pandemic, we were much less likely to admit young people to these observation wards, possibly for obvious reasons, not wanting to expose them to the virus in hospital. Now, we have found several important negative findings. Overall, although Ben will talk to you more about this in terms of fine-grained analysis, overall, we have found no evidence that children from deprived areas were any more or less likely to come to A&E, which was an important negative. We have found that ethnic minorities were no more or less likely to come to A&E. We have found, very importantly, that there was no difference in the chances of young people being offered a follow-up appointment. Admittedly, we included both phone calls and distance appointments as well. And also, we have found no evidence that young people were any less likely to attend their first follow-up appointment. Now, that is a really crucial thing to understand. The time of the greatest risk of suicide for the young person is the first week after they came to A&E with severe self-harm. So in most countries, there are policies to say that you must follow up young people following their presentation to A&E. And we were really worried that we will find that, with the pandemic, with phone calls and Zoom and Teams follow-up appointments, that kids will not be able to, will be less likely to attend these. But we have found no evidence of that, which was an important negative. So with all of these reductions in A&E, massive reductions in A&E presentations, is it conceivable that the reason why these young people did not come was because we admitted them to inpatient hospital? And the answer is no. We looked at hospital admissions in England, during 2019, 2020, and then in comparison to last year. And you can see that the actual number of admissions in England was actually very substantially down at the same time. So we have found just under 250 admissions during April in comparison to the usual over 350 admissions. So that number of admissions, in fact, was the lowest ever recorded in England. So, so the implications of this is essentially what we have found has profound implications. We know that during the pandemic, when young people experience substantial increase in emotional disorders, suicidality, self-harm, they are much less likely to come to A&E. They are much less likely to come to A&E with self-harm, and they are much less likely to be admitted as well. So we have created a situation where a lot of young people are at home, unable to access services. And that's a really important thing to understand for people who plan services. So really the main take-home message from this is that during the second and possibly subsequent waves of the pandemic, one really should not create more A&E departments like we have actually done at the Maudsley. We had this extra A&E capacity. We should really focus on community services and trying to reach the young people who are at home, unable for whatever reason to come to A&E or be admitted to hospital. So developing community services is the key message for this second and possibly further waves of the pandemic. So I'll hand you over now to Ben.
Thank you, Dennis. I know we don't have a lot of time here, so I'll try not to rush everything. Let me just try to share my screen and pick up on the presentation. Okay. So drawing from these results from the main study, there were some questions that we were asked to provide a clearer picture. First of all, our study looked at March and April 2020 data and compared to 2019. But were we actually comparing the effects of having a global pandemic or not? Or are we comparing the effects of lockdown, which was introduced in many countries? Because these are co-current and we want to try to separate them. And how did these measures contribute to our findings? Is it as a mediator or as a predictor? And when lockdown measures changes and updates, what does it mean for self-harm in children and adolescents? So the next slide, we summarize some of these most prominent effects of lockdown policies. We won't have too much time to cover all of this, but I guess we can just go through. It's quite straightforward. So school closure, obviously, disruption to education is a big thing for many children. And this was back in March and April 2020. Now it might be different because a lot of schools are open in many countries. But back then, school closure was such a sudden, abrupt thing for many children, and it might be hard for them to adjust. And also, it might be hard to see that like for half of the parents felt very hard to support the homeschooling, and also the services of healthcare services, they're not adjusted to the whole pandemic. So a lot of assessment and care plan reviews might not take place. And we might see a lot of physical distancing because school is such an important platform for peer contact. And without school, there's basically no contact and children can't go everywhere. And leisure activities and other entertainments might be very limited. And living in small places, a living place might be bad for the family as a whole because stress in parents is actually a significant mediator to children's emotional behavioral problems. And we might have extra concerns for those with pre-existing mental health conditions or those who are looked after. Also, multiple studies have raised concerns of inequalities of school closure. And also COVID-19 has had the greatest impact on the most economically deprived. And we want to see whether this actually lead to a reduced access of professional support. But also we have to keep in mind that these measures are constantly changing and they vary internationally. So different countries have different measures. And most of all, it's very subjective. So how do we combine this with our results? We found a tracker called OxCGRT, and it's a tracker developed by a research team in University of Oxford, Blavatnik School of Government. And basically what it does is collect systematic cross-national information and standardize composite index of these measures to give us a sense of how stringent and restrictive the lockdown policies are. And these are the 9 policy response indicators, which is common policies that have occurred in many countries. So using this information, we're looking at the mediator role of stringent policies and also the predictor role of stringent policies, and how do these affect the presentations and the clinical profiles of those who presented with self-harm. So essentially what we found is a very significant mediation model. If we look at the green line, this is direct effect of year. So let's go to 2020, we see actually a positive relationship. There are actually more emergency psychiatric presentations, but this is overshadowed by the mediation relation through the lockdown stringency. So the total effect we're seeing is actually negative. We see less emergency psychiatric presentations. And the same thing goes with self-harm presentations. We expected more self-harm presentations if there was no lockdown stringency. But in fact, in reality, that is the mediation that exists. And we see less self-harm presentation this year compared to last year. And this is interesting one. It is about a proportion of self-harm presentations. So it essentially is telling us how important or how major the effect of self-harm is within all the emergency psychiatric presentations. And we're seeing a significant positive mediation relationship, but the positive relations between year and the proportion is not significant. So basically what we're saying is lockdown stringency is doing all the work here, is mediating the whole relation. After we have established the mediation relationship, we can look at the effect of self-harm of stringent policy as a predictor on how do children from different deprivation levels present. And if you look at here, it might be difficult to see, but like the darker lines, these are the more the less deprived families, and the gray lines are children from more deprived families. And we see two distinct trends here. As the lockdown got more stringent, people stay more home, we can see that there are less children who are presented for self-harm from the more deprived deciles. And in fact, children from the least deprived deciles, they're more likely to be presented. So this is interesting because if we looked at, just pick out any two deciles and compare, we might not see the same relation. So let's say, for example, this is the third decile, which is supposed to be more deprived than the seventh decile. But in fact, the relationship is inverse. We see less children from the less deprived deciles to be able to present it as NE for self-harm. So which is why that might be the non-significant result in our main study, that we see that there wasn't a relationship. But if we look at the patterns, it's actually very distinct and different, and it's very interesting. If you look at as a predictor, we can see there are more male children get presented for self-harm when it got more stringent, and there are more looked after children get presented. And we also have a record of the precipitant of these self-harm presentations. So as we can see, out of all the precipitants, social isolation becomes more likely a precipitant when stringency increase, which is, in other words, it means social isolation is a more important factor to the self-harm, whereas school pressure and row with a friend got less likely, which makes sense because there were less chance for them to interact with their friends and to be in the school, and there might be a higher level of feeling lonely. So just a recap of our findings, it seems that lockdown stringency mediates the reduction in psychiatric emergency and self-harm presentations. And also the rate of these presentations seems to have increased if there was not any lockdown restriction I received from the mediation model. And we might also want to investigate in the future the potential psychosocial inequality and how do children and adolescents from different deprivation levels, how are they affected by these stringent lockdown measures? Are they affected differently? And we might also want to consider this social isolation as an important factor, because this is very evident that they got more likely to be precipitant when you get more stringent. So what should we do? As Dennis mentioned, help seeking in children and adolescents who self-harm is very rare. And in fact, I think according to a systematic review pre-COVID, there's only about 50%. And this has likely got worse in these stringent lockdown restrictions. So we need to reach and support those with severe mental health needs. How do we do it? So first of all, policymakers and commissioners, they should prioritize funding and develop community mental health services because we need to find a pathway that can reach these individuals. As we can see, like some children and adolescents, they might be less likely to be presented for their self-harm problems. And we can also think about how to reduce social isolation, because this seems to be a major factor nowadays. And stringent lockdown measures we should make it as short-lasting as possible, because we want to avoid the build-up of these psychiatric risks. And when we do it, we want to provide clear rationale. We want to tell people why we do it and how long we're going to do it, because otherwise there will be public confusion or fear or misconception. And these are likely the barriers that prevent people or children to be presented for their problems. And research-wise, we've been looking at specific policies. So we mentioned the tracker, and it actually has a lot of components, and we can look at how specifically each component, for example, school closure, because nowadays we can see this second wave of lockdown, many schools are open in other countries, and potentially we get a new set of data compared to March and April, because back then we don't have school open. And how do self-harm presentation or psychiatric presentation vary in this situation? It's different from back in March and April. We might want to look at specific components. And meanwhile, we might want to look at the perspective of specific deprivation level, and how do the socio-economic status of the family affect the presentation. And we want to prioritize the vulnerable population. As we can see, male children might have more self-harm problems. It is possible, it's potential. We can't have a conclusive evidence, but it's interesting to look at, because that is as the inverse of what the self-harm problem is in pre-COVID. And also looked after children might be something that we want to look at. I hope I covered that in sufficient way. And thank you for the time. And this is all.
Thank you, Mr. Hao-Jin and Dr. Ugren, for very interesting and very informative presentation. We're going to talk about a couple of questions that we've received. First, to Dr. Jabir from Romeo Tolentino Jr. He says, thank you, Dr. Nahed, for your insightful presentation. If the brain developed from back to front, and the brain is under construction as it develops through time, how do you explain the development of a child prodigy or a genius in terms of brain biology? That's from Mr. Romeo Tolentino. Maybe have your thoughts on that?
Yeah, so basically, we're talking about the frontal lobe just as executive functions in terms of problem solving and appreciation of consequences in terms of decision making. And this is when we talk about risk-taking behaviors, and this is very well known, like the concrete and the abstract thinking among adolescents, that how it progresses based on their frontal lobe development. So just speaking about the executive functions in terms of the high executive functions, I hope I explained it well. It's not speaking about the entire brain function. Like, for example, in adolescence year, when we talk about brain development, especially the frontal lobe, that the control of emotions will be probably ruled by the amygdala that's taking place of the frontal lobe in terms of, that's why we see some kind of impulsivity in their behaviors and no appreciation of consequences.
Thank you very much. I was really interested just in some of the data that you reported on, for example, in terms of the use of, or the availability of apps, and just how open that leaves children and adolescents to exposure to things that they're not really prepared for. I have to say that I made exactly the right guess for the number of apps, 2 million, but I assumed that that was a major over-exaggeration. sad to see. You also talked about the level of negative influence in terms of exchanging adult content and the number who've actually engaged in harassment online. Let's turn to Dr. Ugren, and we'll pass on a question from Saqib Latif. As always, excellent presentation, Dr. Dennis. Thank you. My question is, as we know more now about the impact of peers on the initiation of self-harm, what is your view on school-based interventions as a primary means of preventing self-harm in the first place?
It's a very good question. I have worked with Dr. Saqib Latif for many, many years, and it's good to hear from you. Hello, Saqib. Now, the question is excellent in the sense that even though we know what works for self-harm, even though we know how to engage young people with self-harm, there is absolutely no way any country could deliver DBT and therapeutic assessment to every child with self-harm. Not any country, not even Norway can do that. Not even the UAE could do this. So the answer to this problem is going not to lie in our services, in the secondary care services. It will have to lie in the prevention of self-harm, and that can only be done through effective early interventions at the level of the family and at the level of school. So we absolutely must refocus our efforts from plowing loads of money into secondary care and inpatient services into preventing self-harm and psychiatric disorders in very young children, especially the super high-risk groups, such as looked after children with abuse and neglect. Doing school intervention. So exactly right, Saqib. I mean, I would actually spend a lot more money on preventing psychiatric disorders and self-harm and suicide early in children's lives, rather than trying to do something much later. Now, it's an easy thing to say, but a difficult thing to do. And the reason for this is because everybody comes to the government and says, give us money to prevent. But we are not the only people who come. Everybody comes. You know, cancer comes, cardiovascular comes. Everybody comes to them and says, give me £1 now, I'll save you 10 in 50 years' time. But you know, they can't do it because there are also people who need help now. And the overall pot of money is limited. And also, in most countries, governments think in electoral cycles as well. So 50 years is not going to help them to be re-elected. so it's a fundamental question. I mean, if you're asking me, I would definitely spend a lot more money on preventing and school interventions, but the reality is very different, and we can only, I suppose, advocate for more resources, and not just for more resources for the ones who are in the most desperate need now, but in preventing these disorders in the future.
Excellent point, Dr. Ugren. And I'm not sure if you're aware, I myself was briefly involved in a government program in Ireland, introducing DBT into some of the school systems there. I left before any evidence came out of it data-wise, but you may know more about that. But there is this pressure to provide services early on before things become really difficult. There's another question, Dr. Dennis. We don't have a name of the questioner. Thank you for your presentation. I just want to know, during the last pandemic, are there any studies on the effect of such a pandemic in previous pandemics? Are there any studies on the effect of such pandemics on mental health? Is it worse today than before?
The answer is yes. The mental health of children, as far as we could say in the UK, is significantly worse now than with any previous pandemic. Certainly, well, in the last 100 years. I don't know what was it like during the Spanish flu in 1918. But the issue is, we know it for a fact. So the mental health of kids during this pandemic is significantly worse. We have a very large study by NHS Digital just done this year, looking at early on in the pandemic. And the beauty of this study is you can compare the prevalence of psychiatric disorders and their problems now with 2017 and 2004 and 2004 and 1999 and so on. So there's the same methodology that has been applied cross-sectionally over many years. And so this year, the study was done using something called the SDQ, which stands for Strengths and Difficulties Questionnaire. Now, it's not a diagnostic tool, but it gives you the likelihood of a child having a psychiatric disorder. And the estimation of the prevalence of psychiatric disorders in 2017 was roughly in the region of about 10%, about 11% of kids had highly probable psychiatric disorders. In the latest study now, this year, we have found 16% of kids. Now that's a massive, massive increase. It has nothing to do with this gradual, slow increase in prevalences that we have seen for many, many decades. This is a massive, sharp increase in prevalence of psychiatric disorders. And, you know, a jump from 11 to 16% is highly unlikely to be driven by any other reason except for the actual pandemic. And there are many other studies. In the States, there was a study which really struck me. It was published in JAMA Psychiatry just recently, saying that 10% of adults in the USA have seriously considered suicide in the last 30 days. 10%, 1 in 10. It's extraordinary. These are mind-blowing figures, which none of us who are researchers in the field have ever seen before. It's incredible. And so the impact is huge. I mean, one could speculate why it is. And of course, there are many, many reasons for this. You know, one of the key reasons, of course, is that people are getting poorer. And when that happens, for example, suicide rate goes up. You know, the highest rate of suicide ever recorded in American history was during the Great Depression. The same in England. You know, when things go badly wrong economically, the suicide rate goes up, especially in males. Then, you know, so that's one aspect. Another aspect which is important is that we've got social isolation. You know, and that is something that drives human mental health. So we need to connect with people, and disconnecting, especially the vulnerable kids and the vulnerable adults, is something that is going to be toxic for human beings. And there are many, many other factors like that have created this, you know, and we need to be mindful of the fact that children have exceptionally poor mental health now, and so do adults. And it's something that has to be, I think it's really underrepresented in the governmental thinking in terms of how to implement all of these measures to reduce the spread of the virus. I think mental health is not sufficiently prominent in the way that the government thinks about the impact of the pandemic on human health. And we need to really use all channels to make sure that they understand that apart from the physical health problems, there are very substantial mental health problems, and they're not being addressed at the moment.
Yes. Well, we have come to the end of our time, unless we have any other further comments from the panel. Thank you so much, Dr. Nahed Jabir, on providing so much really useful information, including some really helpful recommendations and guidance for parents and the rest of us in managing young people's online access and behaviors during this time. And to Dr. Ugren and Mr. Houching on speaking about the risk and the dangers to our young people that has been really maximized in many ways because of COVID-19. We thank you all and look forward to speaking with you again.